Thank you, Whitney. So, without further delay, let's just get started. So the first, it was supposed to be a wet lab, but we weren't able to get good specimens to show you what congenital heart disease is all about. So I put this presentation, it's more about the general principles of adult congenital heart disease. So I'm gonna get started with a few questions, okay? And these are all the things actually that happened to us. So 35-year-old female underwent cholecystectomy. You got called because the blood pressure in the left arm is 70 systolic. You go, she looks otherwise well, she provides history of unknown congenital heart disease, repaired through left thoracotomy as the only surgery that she ever had. Exam is normal except for ejection systolic click on cardiovascular examination. Your diagnosis is A, patent ductus arteriosus, B, left-sided classic pleural cross-section, coagulation of aorta. Figure out later. Let's start on presses right now. So, I guess we don't need to have this boot camp, but for people who answered coagulation of aorta, what is the thinking? Nothing?
The ejection click is for my contracted valve.
Okay.
There's restenosis on the left side of the ventricle.
Okay. Coagulation for okay. Well, I guess we will talk about coagulation at a later time too. So let's talk about the surgical scars. It's important because maybe the patient will be walking into your clinic without any prior history, without anything that they have, but they will have scars as telltale signs of the previous surgeries they had. So, you know, a lot of surgeries can be done through a medial sternotomy, so sometimes it's difficult to know what they had done. But for left thoracotomy, there's a classic pleurotoxic shunt happens, the coarctation repair also happens to the left side, interrupted aortic arch, including surgical PDA ligations. Those are the top 3 surgeries that you will have through the left thoracotomy. In addition, if you have like vascular rings, PA banding, port shunt, you may see a few of those too, but the top 3 will occupy most of the left thoracotomy surgeries. The right thoracotomy, you could put a BT shunt on the other side, modified Leylock-Tossic shunt, water stun shunt, sometimes atrial septal defects, and other central congenital heart diseases can also be fixed through the right thoracotomy. Okay, moving on. Who does not require, is this mic working?
It is. Both of you need to turn to your side.
Oh, is it? So I should put it in the middle?
Yes. Put it on your side.
Oh, okay. Better?
No.
No, not better? What do we hear? Or should I increase the volume from that side?
That one's as high as it goes.
Really? Can you hear? Okay, good.
That's better.
Okay. So who does not require infective endocarditis prophylaxis? So patient had VSD associated infective endocarditis, but he has undergone VSD closure and he's going to have a dental cleaning a year after the VSD surgery. ASD plus small VSD, status closed at the closure of VSD, dental cleaning at 4 months, so there is still a small VSD left, but the ASD is closed, and he's going for dental cleaning at 4 months after the procedure of at closure. Then the third patient had a VSD, got the patch closure, but unfortunately is left with still a small residual VSD, going for dental cleaning at 1 year. Complex CHD patient who is undergoing cystoscopy. So who does not need infective endocarditis prophylaxis? Patient 1 and 2, 2 or 3, 3 or 4 or 4. Who doesn't need one? I think that's a very reasonable question for boards, right? So think for those patients. it's gonna work. Now it's gonna work. Answers now. I wanted you to go through those present questions. So. So moving on, majority of people got it right. So it's important to review the indications for infective endocarditis prophylaxis in adult congenital heart disease patients or in general cardiology patients. So if you have prior history of infective endocarditis, no matter whether you repair the lesion, you're still going to get IE prophylaxis all the time. Prosthetic valves of any kind, bioprosthetic or mechanical, you have them, you're going to get IE prophylaxis. This recommendation came in envelope plastering and artificial cording. So these need to be treated at the same level as the artificial valves. So you get infective endocarditis prophylaxis all the time, not for 6 months, but all the time. Okay. But if you have like a prosthetic material, like a patch, ASD patch, VSD patch, or Amplatzer device, then you need infective endocarditis prophylaxis only for 6 months until the whole thing endothelializes over. Okay. 4, patients with residual intracardiac shunts at the site or adjacent to the previous repair with prosthetic valves. So if you have a VSD, you closed it, and there's still a residual shunt going on, you will need infective endocarditis prophylaxis forever because that portion adjacent to the patch is not going to endothelialize because it's residual VSD shunt. But if you have the VSD, you close the membranous and you still up with a VSD in the muscular region, then you don't need infective endocarditis prophylaxis because that is not adjacent to the site of repair. Okay. 5, patients with uncorrected cyanotic heart disease, they will need infective endocarditis prophylaxis. A valve dysfunction in heart transplant patient is another indication which is not applicable here, but it's a fair question. Let's talk about this one. A 19-year-old patient with tricuspid atresia and fountain requests reversible contraception. She is taking warfarin for anticoagulation. She has 3 partners and has never been pregnant. Which of the following will you recommend? Essure fallopian tube implant, Mirena IUD, diaphragm, low-dose estrogen, cyclical OCP, Depo-Provera intramuscular injection. Don't judge our patients.
What happened to godliness?
Well, those are not in the choices. So Mirena IUD was the majority of the response. People who have rotated through us, in general, in all the cardiac patients, we love Mirena IUD. And the second thing that we love is just the progesterone-only contraception. We do not like the low-dose estrogen OCPs because of the higher risk of thromboembolism. But for this particular patient, because of the multiple partners, and there is a higher risk of pelvic inflammatory disease. So if you were going to do Mirena IUD, you may just want to tell the woman to use the guard against sexually transmitted disease. In this one, Depo-Provera intramuscular shot probably will be a better answer, but in general, myelina, ideally, if you see a cardiac patient, is a solid answer. Okay. So, when is it appropriate to use combined hormonal contraceptives, which means that estrogen-containing patches, estrogen-containing pills, and that list is actually very small. So, uncomplicated, mild native valve disease, uncomplicated. Fully repaired or very small, simple congenital heart disease, small VSD, or you dash the VSD, there is no shunt left. Bicuspid aortic valve without any dysfunction. Most arrhythmias without atrial fibrillation or flutter, because if you have atrial and flutter, you can cause risk of thromboembolism. Fully recovered cardiomyopathy, including pericardial cardiomyopathy. Uncomplicated Marfan syndrome without any aneurysm. And uncomplicated hypertrophic cardiomyopathy without the enlarged left atrium. And the bioprosthetic valves was also, it seemed appropriate, but I highlighted this in there because that's very controversial. Because the bioprosthetic valves can also get thrombosis too, so we tend not to use it in the bioprosthetic valves either. So, when is it inappropriate to use combined hormonal contraceptive in rest of the other things? So atrial fibrillation of flutter, your LSI is more than 4 centimeter, mechanical valves, cyanotic heart disease, prior thromboembolic event, large shunt lesions, Marfan syndrome with aortic aneurysm, repaired coagulation with hypertension, Fontan heart, coronary arteritis, CAD, diabetes for more than 20 years with end organ damage, more than 35-year-old smoker, uncontrolled hyperlipidemia, uncontrolled hypertension, LV systolic dysfunction of any cause, pulmonary hypertension, and atrial septal defect. Okay, so rest of the places you should avoid the combined hormonal contraceptives. Okay, very important. It's actually pretty common in our clinic for people to walk in and have inappropriate contraception being used, and we have to advise them accordingly. So let's also talk about the modified WHO classification of maternal cardiac risk during pregnancy. This is the latest classification. These guidelines keep on getting revised every 2 or 3 years, but this classification enjoys the current line from majority of the societies. So, maternal risk can be classified into 5 categories. So, with WHO class 1, there is no or mild increase in morbidity and mortality when you are pregnant. WHO 2, these are the cardiac conditions in which there is only a small increase in morbidity and moderate increase in small increase in mortality, moderate increase in morbidity. In WHO 2-3, in these conditions, there is intermediate increase in mortality and moderate to severe increase in intermediate increase in mortality and moderate to severe increase in morbidity. Under 3, there is significant risk of mortality, and morbidity, and in class 4, there is extreme mortality. Pregnancy is usually contraindicated. So low maternal risk, modified WHO. So if you have an uncomplicated small or mild PS, patent ductus arteriosus, mild mitral valve prolapse, it's okay. Successful and completely repaired ESD, VSD, PAPVC, it's all right too. Those are low maternal risk patients, so they can, maternal cardiac event rate is pretty low. Follow up once or twice during the pregnancy, and they can deliver at their preferred local hospitals with their preferred OB. Then there is small to moderate risk, which is modified WHO 2 classification, which there is unoperated, sizable atrial septal or rectal septal defect, tetralogy of flow without sequelae, most supraventricular arrhythmias, Turner syndrome without aortic dilatation. A maternal cardiac event is slightly higher, 5.7 to 10.5%. We need to follow up every trimester, but they can still be delivered at preferred local hospital if everything goes well. And then intermediate mortality risk is, the list becomes a little bit longer. So mild left ventricular impairment, but ejection fraction is still above 45. Hypertrophic cardiomyopathy, mainly for tissue valve disease, not considered to be severe or mild, Marshman or aortic syndrome without aortic dilatation, aorta less than 45 millimeter in bicuspid aortic valve pathology, repair coagulation, AV cycle defect. Cardiac event rate is 10 to 19%, follow-up every 2 months, delivery at hospital where both cardiac and OB expertise is available. Then there is significant mortality risk in that list is even longer. So moderately reduced LVEF, previous peripartum cardiomyopathy, even without any residual left ventricular impairment, mechanical valve, systemic right ventricle, content circulation in a well-compensated patient, unrepaired cyanotic heart disease, moderate mitral stenosis, severe asymptomatic aortic stenosis, moderate aortic dilatation in Martin, more than 40 millimeter and more than 45 in bicuspid aortic valve, ventricular tachycardia. This cardiac event risk is significant, follow-up every month, and delivery again at a tertiary level center. And then these are the patients which actually makes it like a lot of